Good morning and welcome to our first session. This session is going to be very, very interesting, especially for me. My name is Sally Hodder. I work for Stand Tall for PTS. Bit of an oxymoron actually, because I actually volunteer. And it's my pleasure today to introduce our speakers. And the first speaker we have joining us is Janet McPherson. Janet has over 13 years of experience both in the public and the private sector. She holds the dual qualifications in psychology and also in occupational therapy, and has worked in lots of different areas, including occupational rehabilitation, drug and alcohol, and community rehabilitation programs. Currently, she's the team leader for work rehab in Brisbane. With her dual qualifications, she has assisted clients presenting with complex psychological issues and holds a special interest in post-traumatic stress disorder. Janet has presented on this subject at state and national conferences, and she also works within DVA, Income Protection and various other private companies. She was also nominated and a finalist in 2016 in the ARPA Queensland Rehabilitation Awards in the category for Outstanding Consultant of the Year, so very qualified. She's speaking today, and the title of her presentation is Phases of Recovery, a Whole Person Approach. So please welcome to the lectern, Janet McPherson.
Thank you. Good morning. So today I'm going to talk about phases of recovery, a whole person approach to rehab. The World Health Organization looks at health as a whole, complete state of well-being. And so they look at health from a whole person approach. And in my role as a rehabilitation provider and working with people with PTS, I also look at health from that whole person approach. But not everybody does. And we have to ask ourselves why that isn't happening. So in this session, we're going to talk about why we actually need this whole person approach. We're going to talk about how we can facilitate this with some of the practical strategies that we use. We're going to talk about specific outcomes that we've achieved, and I'm going to share a story of one of my clients. But first, let's talk about another specific model of health, which is a biopsychosocial model. Now, this particular model looks at health as a combination of many things. So it looks at health as social, psychological, and biological. Now, this particular model of health is important because it has been adopted by many of the compensation groups. And this is important because most of the clients that we do see with PTS do fall under a specific compensation group. So whether or not that is Comcare, which is under what DVA falls, or whether it's MACE, the Motor Accident Insurance Authority, or whether it's the head of the Workers' Comp. All of them have adopted the biopsychosocial model as best practice for moving forward in terms of rehabilitation. So if we look at it a little bit more, we can see why it is such a good model for looking at that whole person. So it doesn't just look at one aspect of health. It does look at it from the big picture. We look at the biological factors, which we've talked a lot about today already. So genetic effects, drug effects, all those sorts of things. We look at it from the social aspect, the family circumstances, work, peers, the relationships. And then we also look at the psychological side, which we've also, again, already talked about, the coping strategies, the resilience that people have. And so all of these factors interplay, and they all contribute to an overall approach to mental health, and in this case, PTSD. So we do need to think about how we're going to approach the individual who is recovering from a traumatic event and how we can factor all these areas of their life into their recovery. We can take it a bit of a step further, and what we tend to do with our approach is look at it from different phases of recovery. So we look at it from a medical point of view, or we look at it from a psychosocial or the vocational point of view. But what we see is that these phases are continually moving. They're always moving in a circle. We're not just looking at it in isolation. We're not just going, we're just going to look at your work now, we're just going to look at your medical needs. We're constantly looking at how all these factors are interplaying. and moving backwards and forwards in a continuum. I'm going to talk about each of these factors now, and I guess some of the key things that we do in each of these areas. Medical management is probably one of the more straightforward ones. It's one of the things we're talking a lot about today, about the treatments. And treatment access is really, really important. But we also want to have this multidisciplinary and a really collaborative approach. We want to talk about education, and we want to talk about appropriate treatment, which again has really been touched on. We're sort of seeing that there's some treatments, you know, if only 50% of it is effective, where's that gap? Where's that extra treatment? And we also want to think about, again, from that whole person perspective, what other treatments does the person need? I know it will be talked about later today with the Vietnam Veterans Cohort Study, but they're one of the unhealthiest groups in the country. And so we need to look at their health needs as well, and that then translate into all the other people with PTSD. So we need to look at, you know, things like diabetes and things like their heart disease. And then we look at exercise physiology and the role that plays in PTS. So again, it's more than just treating the PTS. We need to look at, again, the bigger picture. Then we look at psychosocial rehab, which is, I think, one of the most important phases of rehab. And I often hear people say, oh, they don't need psychosocial rehab. But everybody would benefit from psychosocial rehab. Psychosocial rehab is about quality of life. It's about getting back into the community, and it's about the aspects of the person that makes them who they are. And so we know there's been lots of research that supports that good psychosocial rehab leads to really good outcomes and really good return to work, really good quality of life. But what does this actually mean in practice? Well, I can't tell you because everybody's different. Everybody has different needs, everybody has different likes, everybody has different circumstances. And so what we can do is approach everyone in a different way and say, well, what can we do for you? What we do know is that one of the key symptoms of PTS is that social isolation, that social withdrawal. And so that's one of the key factors of that psychosocial rehab, is can we get them re-engaged with the community? Can we get them out of the house? Can we get them doing things? So that's where a lot of the service organisations are doing really great work. So Mates for Mates, all the activities that they're running, Soldier On, and the list goes on. We want to be giving that really key support, and not just to the individual, but also to the whole family unit. Again, we've seen that with all the other research. When the family unit breaks down, we know that their factors become a lot harder. We saw when we have a single parent that the incidences of neglect go up. So we want to make sure that support's there. And again, we know that some of these external organisations are already doing that, which is great. We want to look at training, volunteering, anything that gives that person some meaning that's much more than just their diagnosis. And one specific example that I had a client under DVA where they funded horse riding lessons because she had some horses. And so she just went and trained her horses, and that was really, really good for her. She actually went out, took the horses somewhere and trained her horses. And we know the benefit of equine therapy as well, but this was much more meaningful for her. We then go into vocational rehab, which a lot of people think is what rehab should be. It's all about getting back to work. And absolutely, work is good for us. Work is healthy. We don't dispute the health benefits of work. But there's much more to work than just going back to work. And what I really want to encourage is that work needs to be durable, it needs to be suitable and sustainable. So we don't just want someone to go back to work, we're going to do that in a really supported way. I also want you to think, and what we often see is someone say, oh, I can't go back to work, I'm not well enough, my doctor says I can't do it. But we know that there are stages to that, and so you don't actually have to be fit to go back to work straight away. And so what we do is lots of different things. We obviously start by looking at a vocational goal. So what does the person want to do? And if they've been, say, discharged from the army or come out of the police, well, that could be lots of different things. We look at RPL, or recognition of prior learning, and that is one of the most empowering tools we've seen for getting people moving forward. A lot of people come out and they say, oh, after 20 years of service, I've got nothing to show for it. But we know that's not true. We know that all those transferable skills that they have translate really, really well into that civilian world. So can we take them across and make sure that they're getting those skills recognised? And then we look at retraining, and then we start to step them up to job-seeking activities. We use things like work trials and work experience so that they're put back to work, not in a formal job, but a way that they can have some experience, maybe work less days, work in a greater capacity, and then we start to look at that return to work. So you can see that it's a very stepped process. It's not black and white. We're not like, go back to work, because that can be very confronting for someone who's still trying to recover. Okay, I'm going to talk about a client of mine and share his story and share the way that he has proceeded through his rehab. So Daniel came to us in 2015. He had about 15 years in the army, and he'd done multiple deployments. Daniel's not his real name, by the way. So he'd been deployed to Iraq, Afghanistan, Timor, Malaysia, so many deployments. He'd been diagnosed with lots of conditions. He had PTSD, he had alcohol abuse, depression, anxiety. He also had some orthopaedic conditions, because we know that that you come out of the military not just with PTSD, very rarely do we see that. He had a shoulder injury, had an ankle injury, and quite a severe back injury. So when he came to us, he was at what we call a timely engagement. So Daniel was still in the army. He was going through the discharge process, so he was transitioning. So we got and picked him up early. He was very anxious at that time, and he just had back surgery. So it was very much a medical management focus, very much trying to just step him through that transition period. It took 6 months for that transition to happen, and he'd already been through lots of phases before he even got to us. And so in November 2015, he was actually discharged. And at that point, we started to work on the vocational goal. We also got him some RPL. We got him Cert 4 Work Health and Safety, Cert 4 Frontline Management, Cert 3 Business Admin. So some really good qualifications that immediately he put on that resume and immediately made him a really good candidate. But he wanted to work in the building industry. He had some unrealistic expectations about that, given his conditions. So we had to work with him to try and make this goal realistic and make sure that he could actually do it for the rest of his life. So we worked out that we could do a diploma of building design, lots of CAD work, lots of designing. And we helped enrol him at TAFE to do that. It took a bit of work. We had to support him through that process, but we managed to do that, and he started that in February 2016. He was also volunteering at the Children's Hospital at that time, which was something that was really important for him to do, and it gave him a sense of purpose. We had a little setback in July 2016. He had to have more back surgery, so we went back to a much more medical focus, and that flared up some of his PTSD symptoms. There was some anxiety that came with that. There were some psychosocial stresses. He had a wife and a little girl, so we had to kind of address those barriers as they came on. But he managed to return to his studies. And then in January 2017, he wanted to get some experience in the industry. Wasn't ready for work, but wanted to get some experience. So we managed to find him a work trial at an architecture company. And so he started working there, and he did that for 3 months and got some really good experience, and then went back and continued his studies. And this is Daniel today. So he is 8 weeks away from finishing his diploma. Independently, Daniel went and found an internship in building interior design. And as we speak, actually today, he's at the interior design company getting more experience. And he's going to go back to the architecture firm and get some even more experience. So in the next few weeks, we're going to start active job seeking with Daniel. So given all the experience he's had, given the excellent qualifications he's going to come out with, given the fact that he's now medically stable with his PTSD symptoms, he's not taking any medication, we know that he's going to have a really, really good outcome. And so you can see that with Daniel, we've taken this whole person approach. We've looked at, you know, the things that the medical aspects, the psychosocial, the vocational, but we've looked at it from a very fluid perspective, not kind of breaking it all down into little chunks, and very much kept moving him forward. So putting this all together, if we look at it, the whole person approach, we know that looking at each section does work, but we also know that if we work collaboratively together, if we identify barriers as they come up, if we can put in a plan that is the client's goals, then we know that we can achieve really, really good outcomes. And so I put it to you that if you have clients that you're working with, or that you have people that you see out there in the veteran community or the police community, and they're not getting a whole person approach to their rehab, or they're not moving forward, then can we take a step back and go, why not? Because we know that you can achieve that, and we know that you can access that. Thank you.